I want to thank everybody for attending our weekly Q&A webinar with COVID-19, part of the COVID-19 toolkit that we're providing to our clients and our members here at Healthcare Compliance Pros. We're going to do some of the hot topics that have come up. I know that there have been some toolkits and other things that have been released, so we're going to be talking about that. But the majority of what we're going to be talking about, is your questions. So I want you to make sure that you're typing in these questions. Nicole Mark, who's moderating this event, is also going to be handling those questions. And if we can't get to those questions, or we need to do additional research on those questions, those will be handled in addition offline, but the responses will be part of the COVID-19 toolkit and available in our Q&A section as well. So I just want to make sure that if you're on this webinar and you're not participating in the COVID-19 toolkit, make sure you reach out to your compliance advisor or reach out to Healthcare Compliance Pros, and we can make sure that this toolkit is made available to you. Okay, so recent updates. QMS quality reporting systems have been extended from March 31st to April 30th. So that's the program relief response to COVID-19. Any particular updates with regards to that, Chad, beyond just this information about they've just extended the reporting deadline to April 30th?
Well, I think that's a big one for those who'd be on this call. As far as the relief goes, I'll double check though, come back to that just to make sure that I don't miss anything.
Okay. And then obviously the OCR has released some facts, FAQs with regards to the good faith provision of telehealth under the pandemic response. Chad and I just got off of a webinar that we presented for the Bone Society of Florida, Pennsylvania Bones, Georgia Orthopedic Administrators. We just got off of that. The majority of questions that we were answered or asked and answered were in response to telehealth, remote communications, good faith efforts that need to be extended with regards to putting in place as much HIPAA control as possible, making sure that you get verbal authorizations from the patients, that you may put other authorization requirements in place, and some specifics about some of the code sets that are available, and that you should move into E&M coding probably to maximize your reimbursement with regards to that. Now, the OCR also released, or CMS released, some toolkits with regards to telehealth for general practitioners. It's probably going to talk tremendously about this E&M codes and some end-stage renal disease providers toolkits with regards to services that can be provided through telehealth. Any thoughts on telehealth, either of those last 2 points, Chad, with regards to update?
Yeah, so with the telehealth, one other thing that I wanted to add with that, well, and I guess we can talk about that as one of our questions, but really, with the breach enforcement part of that, OCR is pretty clear in their FAQs that if there is a breach due to using some of these devices for telehealth or Skype or whatever, that as long as it was good faith, then as we're talking about here, that you would not be, they're not going to come after you basically for a breach as long as it was good faith effort, and you were doing those provisions that we do every day with privacy and security.
And again, part of that good faith effort is making sure that the patient understands any security vulnerabilities that exist. That Skype isn't specifically a HIPAA compliant platform, that you agree that it's going over public networks, that the information, that the packets that are being transmitted are not specifically encrypted, those kinds of things that don't meet necessarily those HIPAA specific protocols. But a good faith effort to deliver those services while still communicating to the patient that the exposure exists. Now, the majority of your patients are going to accept those vulnerabilities because they want to make sure that those services are still rendered through a telehealth visit. And think about it this way: we have this pandemic. We have telehealth implementation. Maybe this will kickstart not just you as a practice, but could kickstart the patients into, after the pandemic is over, that they're going to want to move into a more telehealth delivery methodology. Now, I know that for a lot of our clients, they were doing post-surgical follow-ups, through telehealth. They were doing some well checks through telehealth. There's other things that they were doing through telehealth prior to this. But now, again, part of this telehealth toolkit, we'll talk about how you can do specific E&M coding. Now, the other thing you need to think about is this is coming from CMS. You need to be looking at your own internal payers. And I say internal, those are specific to your group. What are payers doing in your geographic region about supporting certain code sets that may be available through telehealth in this pandemic? Obviously, CMS starts establishing guidelines, payers fall in line, but how quickly are those payers falling in line with those new guidelines? Okay. Anything else on telehealth, Chad?
Not on telehealth, but I wanted to circle back around to that quality reporting programs relief. So basically what happens, say, if somebody doesn't report by April 30th? Well, what CMS has done is they said that MIPS eligible clinicians who have not submitted any MIPS data by April 30th, you just automatically qualify for what's called the automatic extreme and uncontrollable circumstances policy. So that means that basically you'd have a neutral adjustment for the 2021 MIPS payment here. So they're not going to ding you for that if you don't get it.
So they're not going to ding you. You wouldn't be available to participate in any positive adjustments based on scoring, but you wouldn't get a negative adjustment because of this emergency, right?
Right. And so I think that's a big announcement as well to make.
Oh, that's a big announcement. I know that in talking to a lot of providers, they're doing MIPS because a neutral adjustment would have been perfectly fine. Positive adjustments are better, but reporting up until this pandemic would have resulted in negative adjustments, and they definitely didn't want to get into negative adjustment territory. So, okay. Just on the news yesterday morning, the Surgeon General came out and said, that the coronavirus outbreak will get substantially worse this week. And we're definitely seeing that. It's incredible how the numbers are changing. We did our first COVID-19 presentation back on Thursday. We were updating numbers all the time. I did not get a chance to update the numbers for our presentation with that group earlier today. And the numbers were still down in the low to mid 200,000s worldwide with regards to exposures. Now the numbers are up over 400,000 exposed, and the deaths are above 15,000. So we know that it's accelerating. That curve is accelerating, and as the Surgeon General said, he expects it to get substantially worse this week. Right now, there are not enough people who are out there who are taking it seriously, and that's even happening in Washington D.C. I don't know if you saw the news, but the cherry blossoms or the Cherry Blossom Festival in Washington D.C. was practically standing room only. They had jazz instrumentalists out there playing on the plazas. It was, to look at the news, people were not taking it seriously in places where there were significant outbreaks and significant infections. You see people out in Central Park not exercising social distancing. So, as much as we can recommend that to our clients and downstream to their patients, to their employees, we need to make sure that we're taking this as seriously as possible, especially again for our at-risk patient populations. Chad, any thoughts on that you want to get across? I mean, I know you've been doing some research on where the numbers are.
Yeah, and I think it's especially important in those hotspot areas where there's a lot of outbreaks. Now, for example, I know that when I went to the stores this weekend, you wouldn't know that there's an outbreak going on the way it was. Lowe's was packed, the stores were packed, so just, in those areas where there's outbreaks, we definitely want to be careful, especially there.
Well, what can we do within our practices themselves? You know, making sure that we're communicating, that we're taking this very seriously. Are we doing remote check-in? Are we having our patients check in from the car? Um, you know, hey, I know that I took my dog into the vet yesterday, was sick, had to have a vet appointment. I actually had to check in from the parking lot. They came out, they checked in my dog, took it into the facility. I wasn't even allowed to go into the facility. You know, are you putting protocols in place for, you know, patients shouldn't be escorted unless they need that escort or they need that family member with them? Are those things that you're doing within your practice? Okay. And the Office of the Inspector General has issued a fraud alert with regards to schemes in COVID-19. Scammers are offering COVID-19 tests to Medicare beneficiaries in exchange for personal details. Wow. Seems like what did I say? The scum always rises to the top. Can't believe, you know, that there's people trying to take advantage of this. I saw information about, you know, rapid tests that were available for $4.95 as long as you paid for shipping. There are a lot of different people who are trying to profiteer off of this. But, you know, we know that this fraud alert specifically, it's not just with regards to scamming them, but it's also about some of that PHI that's being exposed. I know that you brought this specifically to my attention, Chad. Did you have any other thoughts on it?
Yeah, I mean, it's just, we see this commonly whenever there's an epidemic or a pandemic. We see it, you know, hurricane season, scammers come in during, and that's, you know, fast approaching. So we should all be well prepared with our response plans by them. But we always see these scammers who want to do these things and take advantage of populations. So I think the biggest thing is just make sure that your employees are aware, and also patients, to the extent that if they call and ask, know that there are some scams out there, and be sure to advise them on this alert.
And I'll tell you right now, Chad's very cognizant of hurricanes, living in the panhandle of Florida. You know, you're seeing that it's looking like shopping, it's looking like business as usual, but it's not looking like a hurricane announcement, right? It's not, the store shelves aren't emptied or anything like that. Are you seeing that?
Not too bad, just like everywhere else, the cleaning supplies, of course, the toilet paper apocalypse is going on across the country. It's happening here. So just those types of things. I think some of the common things you'd see gone in a hurricane, but not quite as much, because I think a lot of it is, you know, where I'm at, a lot of the people are already used to the hurricane mentality anyway, so they're already stocked up and prepared for that anyway.
So we're make sure you're typing in your questions in line. We're gonna move on to some questions. I'm sorry to hear that in Wisconsin we've got empty grocery shelves. I know that, you know, some of the things that have been that they're announcing nationally are that, you know, the food supply chain is not necessarily endangered. People are still going to work. You know, factories are still running. You know, it's amazing is, you know, they're focusing on population hotspots, these large population density centers, New York, Washington, D.C., San Francisco, those kinds of things. But, you know, by and large, you know, employees are still going to work, employees are still going to factories. You know, I'm still seeing plenty of, you know, trucks on the road that are delivering supplies. It just seems to be this pandemic mentality that's causing some of these shelves to be emptied. Okay. You know, as far as what this needs to be over, you know, we have a question that came in. What has to happen in order for this to be over? No new cases for 14 days, 30 days, those kinds of things. You know, I think, you know, that's directly in relation to testing. You know, we think that from the professionals that we interact with, we know that there are, you know, exponentially more cases out there than have actually been tested. So, you know, you're seeing those sharp inclines in in actual COVID cases, but those cases are definitely reflective of not just new infections, but also the increased numbers of testings. Once we get testing in line, and once we can start tracking contacts and exposure elements, we'll be able to possibly get a handle on this moving forward as to when we can start moving some of these isolation procedures or relaxing some of these restrictions. But here in the state of Utah, where I talk about Chad's in Florida, I'm in Salt Lake. They just announced school closures throughout the month of April. School will not go back into session until May 1st. So, again, what is considered over and, what is happening in your specific geographic regions may differ depending on the state or the geographic region that you're living in. Now, I know we have while we gather some of those questions, I know that we have the top 3 questions that we've had come in through ours. How should we manage employees who test positive? Chad, you want to talk about that for a minute? Are you still there?
Yeah, I'm sorry. I bumped my mute button. So, the way you handle employees, you want to perform the risk assessment. Basically, you want to determine if they're, low risk, medium risk, or high risk. So first and foremost, you want to, what symptoms are they having? Are they, do they have a fever? Are they checking their temperature 2 and 3 times a day? If they are having these symptoms, do you implement a work from home policy for them? Or do they go into self-isolation? All those considerations do need to be taken into consideration with any employee who's been exposed, and then go from there. But you definitely want to make sure that they're at least isolating for 14 days if possible. If there is definite exposure, that's definitely our recommendation there.
Now, this goes in line with a question that came in. If a person gets the virus, how soon after having it can they come back to work? Now, again, the isolation process is for 14 days, that after 14 days, they consider to be not shedding the virus anymore. But part of that is determining when the 14 days of isolation starts. Is that isolation on contact? Do we know that we came in contact with a COVID patient? Are they symptomatic and they go into isolation at 14 days? Those 14 days have to be determined when isolation occurs. And it can be, again, on the onset of symptoms, or it could be on the isolation from possible contact. Now, if they get possible contact, they still have to go into 14 days of isolation, but they could never develop symptoms, but they still need to be in that 14 days. Because we know that the standard symptom response is about 5 days, but symptoms can occur up to 14 days following exposure. And if that happens, if, for example, you were to get sick at day 10 or day 12 or something like that after exposure, then you would need to go into 14 days following onset of symptoms, okay? And we do have a link on the CDC recommendations for returning to work following the COVID-19 that's on the COVID-19 work page that we've developed. Okay. What if a patient has a positive COVID-19 test result after being seen for an appointment in our practice? That's part of why we need to make sure that we have proper cleaning protocols, we have proper PPE protocols in place. So we're cleaning between patient visits, that we have proper social distancing, so that even if a patient were to test positive, we are in the low exposure range, because again, we have PPE, we have social distancing, we have proper cleaning techniques as well. Okay. Now, we also talked about, there's a question, CDC and other guidelines saying we need to be seeing only urgent cases. Can we see urgent cases if they're new patients? Well, of course, if you're considering them to be a critical access urgent visit, you should be seeing those patients. Falls are still occurring, other medical emergencies are occurring. So you need to make sure that you're seeing patients who are considered to be critical. We had a question come up in our last webinar session that talked about, are we going to close the practice down? And if we do close the practice down, well, are you going to close that practice down? Do you have surgical follow-ups that could be considered to be critical or urgent? What are you going to do about PT or any of those other post-surgical follow-up appointments that need to be done to guarantee outcomes? You need to make sure that you're taking care of your patients, and even those could be considered critical or urgent. And you need to be still seeing urgent patients. Healthcare is carved out specifically out of the Families First Phase 2 implementation. So healthcare workers are considered to be critical workers. It didn't specifically say just your general practitioners, just internists, just emergency room physicians. It said physicians of all types are considered to be critical care employees, and the employees within your practice fall into that category as well. So you need to make sure that you're keeping your doors open for urgent or critical care patients. Okay.
And I would just add that I think the way that they want you to manage that, and this is the guidance that we're seeing from states, from the CDC mitigation plans and all those types of things, is let's be sure that we're eliminating those non-essential ones and preventing the exposure that way. Those diagnostic exams, let's say, that aren't critical, that you can push off for a period of time until it subsides, try to reschedule those with your employee or patients and avoid that unnecessary exposure for those non-essential services.
Before we move on to question 3 here on the board, we had a question comes in. If we have a patient test positive at a residential facility after they leave, after they leave, can we begin taking new intakes? Again, that's part of a matter of how you're doing PPE, it's how you're doing distancing for patients, and how you're doing cleaning and sterilization of the facility itself. So that's a matter of determining what your exposure guidelines are for your facility type. Okay. Now, number 3 here, are there compliance policies and procedures that should be in place if an employee is allowed to work remotely from home? Now, Chad, I know that you worked specifically on some remote work policies, some mobile device, and mobile devices would be any device that's not within the practice facility itself. That includes employees' computers in their home environment. I know you've worked on that. Why don't you give us some guidance on that, Chad?
So I think, the important thing is to consider, first of all, you're going to have your employees working from home. What systems are they going to be using? Are they going to be using your company-owned systems, or are they going to be allowed to use their own devices? Regardless of what they're allowed to use, you should have a remote access agreement in place that addresses that. So you want to make sure that they're accessing only what they need to do their jobs, and only they are accessing that information. So from a privacy perspective, you want to have safeguards, make sure that they're following those safeguards. They're not allowing onlookers, they're logging out of their computer, even if it's their own computer, they're not mixing their activities. All those types of things need to be put into consideration when you're having work from home, and then it's perfectly acceptable. We have bring your own device agreements that you can access, and those are essential if they're going to use their own device. That allows you a little more flexibility to terminate things in the event that there is a breach that you feel could have been prevented. So different things that can be in place. Basically, it's all those same HIPAA privacy and security considerations that happen in the practice need to happen also in the remote environment. And that's what you're trying to safeguard yourself against. With, I guess I should say, not against.
Okay. Any additional questions that have come in? I know, Nicole, you're kind of trying to triage this, although I've been answering the questions as they've come in.
Yes, I do have one here. If we experience a breach using Skype or something similar for telehealth services during the COVID-19 outbreak, will OCR impose a penalty on the provider for violating the HIPAA security rule?
Go ahead, Chad, that's yours.
Okay, that one. Actually, no, as long as it was a good faith effort and you were doing a non-public facing domain. So as long as you weren't out there on Facebook Live or doing one of those types of things that is public facing, or let's say that you had something that was very unique and you wanted to advertise that you do telehealth and you accidentally posted PHI on your Facebook page or something along those lines, as long as you're doing it in accordance with, it's for a patient visit, you're using Skype for only that non-patient visit or non-public facing, so it's just between you and the patient. You've given the patient some disclaimers that say, hey, you're authorizing me to use Skype. There are some different, possibilities for interception and that kind of thing. So that they understand some of the insecurity there, you'll be fine. So no, they wouldn't do a breach in that, or they wouldn't enforce it at that point, as long as you're doing those things.
Okay, a follow-up question here to that came in. Are patients permitted to verbally consent for telehealth services? And if so, how should we document it?
Yes, they are, and in fact, that's encouraged. You do want them to verbally consent to using it, and then just make sure that you're, once again, it talks about part of the consent process is making sure that you're documenting and that you've discussed risks. And in this case, the potential risk is, if you're using Skype or something that's not HIPAA compliant, there is that risk of, exposure. If you're using something that's HIPAA compliant, it might vary a little bit. But really, you just want consent to say, hey, we're going to go ahead and do this telehealth, visit, am I okay to proceed? And you understand the risks and that kind of thing.
Okay, and then we have one more here. If employees do not want to use their PTO or sick leave because they do not want to come in due to the virus, what does the Family First Recovery Act say about this?
Do you want me to take that one, Eric, or do you want to take that one?
Yeah, you submitted that question. Go ahead and take it, Chad.
Okay, so basically the FMLA and paid sick leave provisions, as we've talked about, do apply to private employees with fewer than 500 employees. But there are some special cases to where maybe healthcare providers or emergency responders and those types of things may not apply under that. However, you may have some non-essential employees that you determine it does apply to that. So really, you'd want to work with the patient to find out, if they're wanting to take non-PTO or whatever your policy is in place at that point. And then from there, there's the paid sick leave for COVID-19 under the Family First Act that came out that have some considerations as well. And so we have some links to that information. If you'd like that, we'd be happy to provide it.
Great, thank you. That's our last one, Eric.
Okay. Well, again, I want to thank everybody for coming on. We do have a couple of questions that we didn't get to because we answered offline with regards to, authorizations for travel, some other things that are out there. So again, if you have questions, make sure that you are submitting those questions to support@hcp.md, and our compliance advisors, our compliance department is working hard to get those questions answered, okay? And then make sure that you're participating in access to the COVID-19 toolkit resources, and reach out to your compliance advisor if you have any questions with regards to that. I want to thank everybody who was on this and those who submitted questions. We'll be doing this webinar weekly on Tuesdays. Not only will we have the most recent updates on information, especially information that has come in over the weekend, but we'll also be asking or answering the most relevant questions, the most highly anticipated questions that have come into us over the preceding week as well. Will be part of this ongoing webinar series. All right, I want to thank everybody who came on. Thanks to those who participated and submitted questions. And of course, take care out there. Take care of yourself, take care of your families, take care of your patients. Thank you all for coming.